So thank you everybody for joining. My name's Ella Daniels. I'm one of the ACP Trainee Committee members, and I'm also a Medical Oncology ST4 in 7, working at Bristol Cancer Centre. It's my pleasure to host this evening's webinar on non-small cell lung cancer. I think it's been about a year or 2 years since we've had an update in this webinar series, and obviously a lot is changing and evolving in the field. We've got some really interesting speakers, so I'm excited to announce we've got Adam Januszewski, Ali Greystoke, and we also have Paolo, one of the trainees from the Royal Marsden. The webinar series is uploaded to the EBN platform, which is available to all ACP members if you'd like to watch the session again afterwards. So without further ado, it's my pleasure to introduce Adam Januszewski. So Adam is a consultant medical oncologist at Barts Thorax Centre. He's got an extensive clinical and research portfolio in lung cancer, and he's going to be talking to us about systemic therapies in early lung cancer. So Adam, I'll hand over to you to share your slides.
So thank you very much, and thanks for joining, everyone. My name's, as Ella said, Adam Januszewski. I'm an oncologist based at St Bartholomew's Hospital, and I thought it would be interesting to talk about some of the roles of systemic therapy in early stage lung cancer, because this is a field which traditionally hadn't changed very much over the years, but in the last couple of years there's been a few new developments which I think would be worthwhile discussing. So over the next 20 or so minutes, I'll talk about a couple of current treatment pathways, some outcomes, some evidence around current treatments, and then the new evidence and pathways. So this is the pathway, as many of you may know, to definitive treatment in early stage lung cancer. And there's been a move across the country to improve outcomes, as we all know. Earlier diagnosis, faster diagnosis, and these are some of the documents that are describing those things. And actually, where is the role of an oncologist in this pathway? Because traditionally, we only get involved at the end of the pathway, either after surgery or after in the advanced disease setting. This data from CI UK just shows some of the outcomes that we see in early stage lung cancer. And I think we sometimes underestimate or overestimate, how well people do. So you can see here the bars that how frequently patients get there, or according to stage, and the dots are their outcomes. And you can see the majority of patients, unfortunately, are diagnosed with advanced disease, but even those with stage 1 and 2 disease, their 5-year overall survival is not very good. And therefore, there is a role in terms of stage shifting, so diagnosing earlier, either through targeted lung health checks or some kind of screening, which is not currently up and running, or indeed, in fact, maybe the role of us as oncologists improving those 5-year survivals. And the other thing, which I think is important, we'll come towards the end, is the role of optimizing patients to ensure that patients get the optimal treatment prior to definitive treatment, and that a lot of interest in prehabilitation and indeed rehabilitation, which is keeping people fit while they're on treatment. So what have we been doing in terms of systemic therapies in early stage lung cancer? So traditionally, we've been using a lot of adjuvant therapies. This slide here just shows you some of the more significant advances in systemic therapy for early stage lung cancer. Above the line, adjuvant therapies, and below the line, neoadjuvant therapies. And over the next few slides, we'll talk about some of these cases and indeed. So many of you may know or be aware of some of the data around the use of adjuvant therapy treatment after surgery, with an absolute overall survival benefit of around 5% of 5 years. This is based on large meta-analyses looking at a number of different studies. But the question is, why don't we use it in the neoadjuvant setting? And actually, when you look at some of the neoadjuvant data, when you put together in a meta-analysis, the data is actually quite comparable. Again, about an OS, 5% benefit in OS at 5 years. There's a hazard ratio of about 0.87. So you can see those graphs look pretty similar with similar kind of data. As you know, there's no head-to-head comparison between those. But as a community, we tend to have settled with the adjuvant setting. There's a number of different reasons for that. That could be performance status, motivation to get onto a definitive treatment, physical fitness, biological rationale. And some of these would be pros for using treatments in the adjuvant setting, and some indeed for neoadjuvant setting. But complications of systemic therapy precluding surgery, indeed complications of surgery that may preclude adjuvant therapy. But just run through some of the adjuvant therapies that we've been using. As I've discussed, platinum doublet therapy has been the order of the day for a few years now. It's a platinum doublet, which, as I said, gives a 5% OS benefit of 5 years, and typically is used for those patients with a tumour larger than 4 centimetres or have nodal disease. The caveats when we look at meta-analysis that you need to have completed 4 cycles of treatment to derive that benefit when you look at the post hoc subgroup analysis, but also they need to have a good performance data. This is data that's been used for some time. What we've been doing is trying to improve those outcomes. And this data from a couple of years ago, looking at the use of adjuvant immunotherapy in the form of atezolizumab as part of the IMpower010 study, was one of the first, well, is the first, other than durvalumab, using adjuvant immunotherapy post-surgical resection. And this is now licensed for use, and we use in the UK. And you can see that this, although the overall survival data is yet to be mature, the disease-free survival data you can see in front of you shows that there is looks to be a benefit, although we will await for the overall survival. But when you look in terms of the subgroup analyses, looking at the different PD-L1 status, is that the order of benefit seems to be derived from the strongly positive PD-L1 status. So that's where we currently use adjuvant immunotherapy after the completion of adjuvant chemotherapy to give a year's worth of atezolizumab. This was the first kid off the block, but in fact, pembrolizumab in the form of Pearls and Keynote 091 was the second to produce data of using adjuvant immunotherapy post surgery. Now, this data is slightly different and it's not yet licensed, and that's because the outcomes are slightly more confusing, and there's a lot of debate within the community about this, because if you look at some of the subgroup analyses, you see that the PD-L1 status, the benefit seems to be derived from those with 1 to 49%, as opposed to the highly positive, which is, you can see this disease-free survival curve. There's a crossover of those curves, which is interesting, and there's been lots of debate about what the reasons may be that, and I haven't been convinced by any of the discussions so far. But this is another potential for use in the adjuvant setting, although it's not currently been reimbursed or licensed. The first, I should have potentially started with this one, but this is the first use of adjuvant immunotherapy in the form of durvalumab after concurrent radiotherapy. This is used for a year, and you can see that the overall survival benefit here with a hazard ratio of 0.72 is significant. And so these patients would receive 2 cycles of platinum-based chemotherapy alongside their radiotherapy in those with no positive disease and a positive PD-L1 status on their resections on their biopsy specimen. So that's the immunotherapies that are currently used in the adjuvant setting. Moving on to some of the targeted therapies used in the adjuvant setting, which is new data that has also not got overall survival benefit as yet. You can see that this is the ADAURA study, which looked at the use of 3 years of osimertinib after completion with or without adjuvant chemotherapy in those with EGFR mutant, common EGFR mutants. And you can see here, this is disease-free survival, that appears that there's certainly a hazard ratio of 0.27, but this again has not shown, has not yet got overall survival data, but based on this data, achieved licensing, and we are now able to use this in the adjuvant setting. But there is concern that that amongst the community that if you look at what happens at the third year, is that potentially what we are doing is pushing out the management of metastatic disease as opposed to curing disease. But the difference is quite high, and ultimately we'll need to see the overall survival data before we make any firm conclusions. Certainly there seems to be, from a disease-free survival perspective, better CNS control as well. I've not got that graph with it here. So that's what we've been doing to improve outcomes using medicines in the adjuvant setting. But as is a paradigm within oncology, you use medicines in the advanced second line, into first line, then adjuvant. And then can we use some of these more effective systemic therapies in the neoadjuvant setting? And that is what I'm going to talk about shortly now. So again, I'm just going to talk about some of the pros and cons of using systemic therapies before and after surgery. Obviously, performance status is very important. Systemic therapy can impede that and therefore cause issues with surgery. But similarly, conversely to that, often patients arrive to you after their surgery with a poorer performance status. So there's arguments for and against for that. There's this idea of motivation that if you've got a definitive endpoint at being surgery, that patients may be more motivated to get through it. As I said, physical fitness, there's a biological, you could question that there's maybe a biological rationale behind giving systemic therapies, particularly in the form of checkpoint inhibitors, while you've got disease in situ. And then, as discussed before, complications of systemic therapy, you don't want that to preclude patients moving on to definitive surgery. Similarly, you don't want complications of surgery impairing the ability to deliver adjuvant therapy and compromising the optimal care. So I'm going to talk about the main study that's certainly been licensed and but not yet reimbursed within UK, and that's Checkmate 816. This is a phase 3 study looking at the comparing chemotherapy with chemotherapy and nivolumab for patients prior to surgery. They would receive 3 cycles as neoadjuvant therapy, and then within 6 weeks they would go on to have surgery. They would then have the option of having adjuvant therapy, and this is for those patients with a stage 1B, so larger than 4 centimeters and node positive. So the outcomes that were measured in this study included pathological complete response and event-free survival. So you can see this is the event-free survival curve. You can see that this separates quite early on for about 6 to 9 months. And you can see here that there is a hazard ratio here of 0.63. But let's have a look at some of the other data in terms of other primary outcomes that have been pathological complete response. We can see that in the chemoimmunotherapy arm, that 24% of patients had a complete pathological response, that is, no viable tumour when they had the resection, which clearly is quite significantly different to the 2% in the chemotherapy alone arm. When we start looking at the overall survival, you can see that at the 12-month mark, the curves start to separate. And we're here with a hazard ratio of 0.57. You can see while the median overall survival has not yet been reached, those curves seem to be significantly separated. So based on this data, it achieved licensing, although not yet reimbursed in the UK for the use of neoadjuvant chemoimmunotherapy. But the question is, how many patients, and are we doing a disservice of patients getting to a definitive surgery? So when we start looking at some of this data, and you look through the supplementary and some of the data, you can see here that of those patients that were randomized to neoadjuvant chemoimmunotherapy, around 93.8%, 165 completed the treatment, and 1 had disease progression. But then if you look further and you want to look at those at the surgical outcomes, which I think is an important metric here, you can see that of those in the Nivo chemo arm is 15.6% didn't have definitive surgery. And that's not a small proportion of patients. So there's those that there were here that had disease progression, and those others which are starred. And when you start looking into the others, that includes patients with poor lung function that were unable to proceed, those that are unresectable. This cohort was all a resectable or perceived to be a resectable cohort. So they were probably incorrectly allocated in the trial. So you can see that some of those others are not true reasons to not deliver chemoimmunotherapy for this cohort. So I think this certainly has been very interesting data. People are very excited about some of this data, about improving outcomes and potentially in this early stage setting by giving patients before surgery. But it's important that actually this is the pathway I showed you at the beginning of the talk, is that actually patient selection will be critical to this. Because to arrive at a definitive treatment modality, whether that be chemotherapy, surgery, or radiotherapy, there may be different routes to that: straight to surgery, straight to chemoimmunotherapy, which patients are suitable for neoadjuvant therapy, and in the future, will there be other neoadjuvant, either in the forms of systemic therapies or indeed in the forms of other modalities such as radiotherapy. And for me, I think it's important that we have a multidisciplinary approach to this, because ultimately, in order to get the best outcomes for all these patients, you need a whole team involved with their care in order to either optimize and keep well, so that we are able to provide the best care to those patients. And there are a number of different factors, both disease factors and patient factors, that may determine which patients go down which route. And I think that needs a whole team of people, including the nurse specialists, to be able to advocate for those patients. Because as we know, in lung cancer, because of the nature of those patients, they often have poorer performance status and are indeed from the most deprived areas of society. And therefore, if we are going to ensure that our patients get the best outcomes, we need to make sure that we optimize them and give them access. I was going to quickly run through a case, but actually time is ticking, and I think that probably it'd be better to have some questions. I was going to it's the patient that is of a borderline surgical candidate, but actually has N1 disease. She's large and she's got a high BMI. She's also diabetic, and I've not got an answer for this, but I think it's these kinds of patients she has a high PD-L1 status, borderline PS, but potentially could be operable, that may have where there isn't a definitive answer right now, but actually through the use of optimization, and could potentially go through down the route of neoadjuvant therapy prior to surgery. Certainly here at St Bartholomew's, and this is part of why, is that we now have an early stage lung cancer clinic which uses a multidisciplinary approach with our healthcare professionals to be able to optimize patients. Now, we've only been using that in the adjuvant setting at the moment because we don't have access to neoadjuvant therapies, but certainly we've shown that we've increased our rates of completion for adjuvant therapies since the inception of the clinic. We've been developing an educational program, which I think is important to help reduce health inequalities. And we also have a tech-enabled app to help rehabilitate, rehab the patients, as well as collect information, PROMS information on patients, which will be important in the future. So I think there's a lot of things going on in this space in early stage lung cancer. I've not talked about the many different trials looking at different combinations of agents, which are yet to read out in terms of both targeted agents as well as other immunotherapy combinations, indeed other immunotherapies from other manufacturers, but they are some of those are soon to read out and likely to compete potentially with the current standard that have announced. So I think this hopefully will change in the near future. And I think it is the role of the oncologists that may be pushing this 5-year survival curves up, and indeed potentially making some of these more advanced stages, downstaging them as there is likely to be trials, in fact there are, that look at those more borderline resectable cases and downstaging those to enable surgical resection to happen. So I think it's a very exciting space. I think that it is changing every few months to years, and therefore I'm going to leave it there. But I think that it requires a different approach, because there will be different pathways for patients to get to treatment, and for patients to see an oncologist before they see the surgeon is somewhat unusual in lung cancer, but not in others. So thank you for your time. I hope that was vaguely interesting and a kind of high level overview of where we are in early stage lung cancer. I'll be happy to take any questions.
That was fantastic. Thank you, Adam. I think it highlighted how increasingly complex this field is becoming. Very exciting, but lots of potential choices to speak to our patients about. We'll take questions for Adam's talk now, because he has to shoot off rather than doing a panel discussion at the end of both talks. Paolo has put a question in the chat. So KN816, did the optional adjuvant treatment include only chemo or nivolumab as well? Did they treat patients during the pandemic, or had they completed recruitment? I can imagine managing to operate within 6 weeks of completing neoadjuvant chemo IO was tricky during the pandemic. Good point.
Sorry, I think I've misspelled it. It's checkmate, not keynote. Sorry, apologies.
Okay. No worries. We all do that sometimes. Whilst Adam's answering that, if anyone else could pop questions in the chat, that would be great.
And the adjuvant, it was just the chemo. The Nivo is only as part of the neoadjuvant setting. When did it occur? I think it overlapped with a little bit of I think it was during the end of the pandemic, but I can't remember the exact dates. The beginning, sorry, I meant the beginning of the pandemic, overlapping.
Thank you.
Okay, so Richard's asked a good question. How easy do you think it will be to convince MDTs to change practice? And then we've got another question from Andy. How do you manage with the delays to getting moleculars back when planning neoadjuvant therapies, and how does that affect you where you are?
I think it's an educational thing for MDTs. I think understanding the data is important, and understanding why patients don't get to definitive therapy when they don't, because that's what some of the anxieties around some MDT members are. I think that patient selection is so important, because some of the first patients that MDTs may be pursuing neoadjuvant therapy, the outcomes will either make or break an MDT if a patient does well, or if the wrong patient is selected to then go on to neoadjuvant therapy, and then their experience, anecdotal experience, then may impact what the MDTs think moving forward. Really, what we've done here is had regular educational kind of audit days with the whole of it, MDT, to ensure that they're aware of what's going on and engaging with them early, as well as setting up everything ready to go for when we are able to use it. In terms of moleculars, yes, I'm sure Alastair will talk a little bit about this, but it is an issue across the country. Ultimately, the pathology you need to know prior to neoadjuvant therapy is potentially EGFR and ALK. If you go by the kind of the trial, you can run some of that on the biopsy samples, and it depends which technology you use. You can get some rapid EGFR, and obviously ALK doesn't take too long if we want to go down that route. Ultimately, certainly in my centre, it takes 2 weeks to get a chemotherapy slot anyway. So, there will be 2 to 3 to 4 weeks in any case, but certainly the very basic moleculars that you need is PD-L1 status, ALK, and EGFR, which in my centre we can do at EGFR in 48 hours using an old-fashioned PCR, with the acknowledgement that you're likely to get additional tumour material at site of resection. But Alastair may have different thoughts about what is and isn't required.
Okay, a couple more questions and then we'll move on. So do you give adjuvant IO after tumour has changed from unresectable to resectable after triplet therapy? Samir, is that somebody that have considered unresectable and given
So yeah, that's
therapy?
a very good question. And because the data isn't there yet, because the Nivo chemo arm was discretion of the in terms of using adjuvant therapies, I actually don't know. I don't know what, I think I would go with the same criteria that the adjuvant therapies would be, in the fact that if you've resected and you have a tumour that's larger than 4 centimetres because it's not had a response, then you may give some adjuvant therapy, and then you'd have to consider, ultimately, if they've not had a good response to the neoadjuvant therapy, then you may question the benefit for ongoing immunotherapy. Ultimately, we need trials in this space, and the trials, some of the trials that will be reading out are kind of the perioperative trials as well. So they give treatment before and as well as afterwards. So that will give us some information, but the adjuvant side of things is embedded in the future in the studies that are upcoming.
Great. And then just the final question, is there any role of targeted treatment coming up in the neoadjuvant setting with EGFR mutated patients?
So yes, there is. There's osimertinib in the neoadjuvant setting. Data is not yet back. I think for me, the molecular drivers are slightly different, and definitely a different, and therefore, I think to think that it may have the same order of benefit that the immunotherapy combination is I think wrong. So I think we need to wait for the data for that. If for example, if you look at ALK, we've looked at our last 5 years of ALK data. And you only get those typically present in a more advanced fashion. So not every mutant is the same, and therefore directly correlating, I honestly don't know, and I think we just need to wait for the data. And Alastair was about to unmute and say something. Go on.
No, I completely agree with you. I was nodding my head. I was just getting myself ready to talk so that.
Okay.
Well, I think that leads in really nicely. So thank you very much, Adam, for your talk. That was fantastic, and all the best with your next talk this evening. I will hand over the baton to Dr. Alastair Greystoke, who's a consultant medical oncologist in Newcastle, specialising in lung cancer as well as early phase trials and drug development. Very relevant for the last few questions. He's going to be talking to us about updates in oncogene-addicted non-small cell lung cancer. And as Paolo pointed out to me earlier, actually very topical, because I think ESMO released some guidelines today on oncogene-addicted non-small cell lung cancer. So I'll hand over to you, Ali, and your slides are sharing, so that's great.
Yeah, so thanks very much for inviting me to talk, and I hope you find it useful. So I work up in Newcastle, but I also do quite a lot of genomics testing. So I work within our genomic laboratory hub, and I will talk a little bit about the testing, because obviously that's key to identifying and treating these patients. And so, yeah, those are my disclosures. So the first thing I wanted to show, you can't be an oncologist nowadays without showing a pie chart. And this is one of the sort of favorite ones that people now show in terms of potentially treatable abnormalities. But it's to show that there is a wide range now that we can treat. And if you're a believer and you look at these potential pie charts, you're looking at maybe up to sort of 50% of patients that we may be able to treat who have lung adenocarcinoma. We can maybe talk about other subtypes of cancer with targeted therapies. With the only one there that's not yet available in the UK, but is available in the US, targeting HER2. And so that may come through later this year or maybe next year. And I've also highlighted there that many of these are enriched in non-smokers, but there are some abnormalities that we may just touch on. that are not so, and in particular KRAS G12C is found more in smokers. And I work up in the northeast where my population is heavily biased towards the smoking and the ex-smoking population. So this is my own particular pie chart for where I work in the northeast, and you can see that even there, where most of my patients are smokers, we still identify probably about a third of our patients have potentially treatable abnormalities. We see higher rates of KRAS G12C due to the smoking, and I have yet to see a NTRK fusion lung cancer, although there have been one or two in the northeast that I'm aware of, but not within my practice. But this is becoming an increasing part of our workload. So, yep, this won't be comprehensive. I spotted the new guidelines this morning as well. You can see my slides are hot off the press. And, if you want to do it now, when you're preparing for your exams, there is now a beautiful guideline that's been produced by ESMO as to, the management of oncogene-driven lung cancer. And I'm not going to be able to cover all of that in 20 minutes, and I wouldn't dream of even trying. To tell you the truth, I couldn't even probably cover one of those. But I want to give you some idea of some of the issues that you may address when you're thinking about how to integrate these new drugs into management. One of the other things I did just want to show is that even for those of us who work in areas with high smoking, actually the rates of non-smoking related lung cancer are going up. And they do seem to be generally going up both as a proportion, but as absolute numbers over time. And if you've heard Charlie Swanton's recent talk, that's probably related to pollution and potentially exposure to some of the things that are generated in traffic, some of these microparticles. And I would advise you to listen to his talk. So if you take non-smoking related lung cancer by itself, it's actually probably the 7th or 8th most common cancer. So we are seeing more of these anyway. So I was in your position about 10 years ago when we got the EGFR inhibitors coming through. And to start with, when ALK came through, we started to think, use the EGFR paradigm. And Adam suggested, well, maybe they're not all the same. So that EGFR paradigm for targeted therapy was that, we'd see these patients pretty rarely. And that was mostly never smokers. And that we could then give these patients, we could run up as the oncologist and shout, stop, and pull away the chemotherapy drug at the last minute and give them a tablet, which was oral and well tolerated. And the patients did extremely well and had a better prognosis. And also, increasingly, we found out that maybe when we gave these patients single agent immunotherapy in the second line setting, which was what we were doing 5 or 6 years ago, wasn't the best thing. So is that true for where we are now? And I'll try and show you some data to justify that. So the first thing, and this goes to what Adam says, is that not all the oncogenes are the same. And this is the type of graph that you're never allowed to show, but it's actually really quite interesting for us to play with. So you can see there's the oncogenes that are in those guidelines, and you can see that's there's what we regard as sort of a classic oncogene, such as EGFR and ALK, where you give your tablet and you see a 78 to 80% response rate, and you get progression-free survival of 1 to 2 years. And sometimes with some of these fusions, such as ALK and NTRK, you can actually see even longer periods of disease control, and certainly major impacts on survival. And then there's also some of these oncogenes that are more difficult to treat, such as the MET, the KRAS G12C, and the EGFR non-sensitizing mutations. And the question then is it that they're more difficult to treat, or is it that we don't have the right drug yet? And I think we'll just learn this over time. So that's the list of drugs we've got at the moment. You don't need to take any notes or anything like that. That's adapted from a slide that Hazel O'Sullivan kindly shared with me, but you can see that we have the whole point about being able to identify these is we have a range of drugs available. I'll show you my cheat sheet at the end that I share with my MDT members. So EGFR has been the lead for precision medicine. That was partly because of the different demographics that we talked about, different treatments, but it was also this sort of paradigm shift in how we looked at non-small cell lung cancer, and also how we were setting up some of the studies that we were running about 3-4 years ago, looking for extra treatable abnormalities, such as the lung matrix study in the UK that I was heavily involved with. And things, just changed so quickly over a period of about 10 years. So EGFR was actually discovered in the late 1950s as a second ever oncogene discovered by dropping extract of mouse salivary gland onto tumors and showing their growth. And just as I was coming out of medical school, we got these tablets coming through, and some patients did really well, but we couldn't work out why. Eventually, we worked out as the mutants, and then we found that they were all getting resistant through, well, many of them getting resistant through T790M. secondary mutation that was stopping the first and second generation inhibitors coming forward. So we developed the third generation inhibitor, osimertinib, and then moved forward into the frontline setting. And as Adam said, it's now moving into the adjuvant and the neoadjuvant setting. And actually, we've been very lucky in that we've been able to access most of these relatively quickly in the NHS. So in fact, I treated my first patient in the NHS on osimertinib at the same time as I was still looking after the first patient ever treated in Newcastle on the phase 1, who was the second only patient in the UK ever to receive that drug. So just to show you the type of studies that we see coming through and how we need to interpret those. So FLORA is the study that drives our first-line EGFR treatment, and it randomized patients who had sensitizing mutations to either osimertinib or an EGFR comparator, first-generation EGFR comparator. Patients had to be fit and they had to have stable asymptomatic brain metastasis, and we'll talk about some of the issues about that. And then if they progressed and that was confirmed centrally and they had T790M, then they could move over onto second-line osimertinib, so you could try and sort of rescue them with second-line treatment. And it was a positive study. It had 2 New England Journal publications. You can see here the survival curve, so we do actually see a potential survival benefit. So that's great, and that's still driven our first-line treatment. So what's the problems? Well, so the number one is, these patients are young. They often have brain disease, and they come to you and they go, oh, no, they've got metastatic stage disease. And then everyone feels happy because they've got an EGFR mutation, and you can give them a nice tablet. And some of these patients will do extremely well, but on average, 19 months on or less, if they've got CNS disease, you will see disease progression. And then you have to think, well, what do we do next with these patients? And unfortunately, as you come forward to being a consultant, 19 months doesn't seem very long, or even 2 years or 3 years. And, when we were first looking, when we were looking at resistance to first and second generation EGFR inhibitors, it made a lot of sense. A lot of these patients were becoming resistant by getting mutations in how the drug bonded, and they're stopping bonding, and that was T790M, and you design a new drug and it can then bond. Unfortunately, when you get resistance to osimertinib, it is far more complicated. We see lots of different resistance mechanisms coming through, some of which have potential new drugs coming through in trial, and a lot of which don't. You sometimes see histological transformation, including to both small cell lung cancer and squamous cell cancer. And interestingly, you see slightly different resistance mechanisms if you treat in the first-line setting than you do in the second-line setting. And in fact, just last year, we saw this interesting data presented at World Lung showing that actually the resistance mechanism may even change over time. So patients who are going to become resistant through MET amplifications, where we may be able to target with drugs, it tends to happen slightly earlier than the sort of other mutations in the EGFR that again stop the osimertinib binding. So it's a really complicated picture, and it's splintering the patient population and making developing new drugs really quite challenging, so that we don't have great options at present time, except potentially for MET amplification, where there's some interesting drugs coming forward. I'm going to skip over that for the purposes of time. And then, so what do we do with these patients second line? Well, we have access in the NHS to this combination of carboplatin, paclitaxel, bevacizumab, and atezolizumab, ABCP, so-called. And that's based on a subgroup of 50 patients who had EGFR mutations in the trial. So, and where we show survival benefit of adding atezolizumab on top of bevacizumab, carboplatin, and paclitaxel, which is not a commonly used regimen in the UK anyway. And, we have to, in terms of giving this treatment, so I use this day in, day out, but, the BlueTech form demands that we use full dose carboplatin paclitaxel, which are bigger doses than we could commonly use in the UK, and using a 4-drug combination in a lung cancer patient population can be challenging. And we don't know what the advantages of that are over sort of simple carboplatin pemetrexed, which would be our standard sort of treatment regimen. I'm not going to talk about co-mutations for time. Importantly, performance status, we know this is a big driver of population. FLORA, as I pointed out, was 0 to 1. Because of this, the BlueTech form that we have to click says that patients have to be performance status 0 to 1. But we know that if you look at the National Lung Cancer Audit data, only about 50% of patients actually are performance status 0 to 1. So how do we treat these patients? Do we give them an inferior drug, or do we say that we think they are performance status 0 to 1 on the BlueTech form? So that's what I wanted to say about EGFR. I'm going to move on to ALK just to demonstrate a slightly different problem in terms of optimal treatment. So this is the nice present guideline for ALK. So we started with our first generation inhibitor of crizotinib, and then we started to develop second generation inhibitors. So ceritinib, alectinib, and brigatinib, and ceritinib went a bit out of fashion because of its GI toxicity. So we basically used alectinib and brigatinib as our frontline treatment option. And then we had a third line treatment option of lorlatinib, a third generation ALK inhibitors. So again, going back to that paradigm that we had from osimertinib, should we be using that in the frontline setting? And I'll show you what the trials look like. So here is where we really start to move into problems, because things have moved so quickly. So they've moved even more quickly than they have in the EGFR space. So all the trials that we have, be it of a second generation alectinib or brigatinib or lorlatinib, compared to crizotinib. Now, I haven't started on somebody on first line crizotinib in, I can't remember, 5-6 years. So, the standard of care arm is not a standard of care. And we know that these treatments are much better. But the question is, which order should we be using them in? And the clinical trial data doesn't help us. So you can start to look at the biology and say, well, lorlatinib covers most of the mutations should we in the test tube, and it covers even some of the mutations that you see emerging on the first and second generation inhibitors. Should we be using that up front? You can again be relatively naughty, and you can start doing cross-trial comparisons, looking at the percentage of patients that have their disease control under 1, 2, or 3 years. But again, that doesn't really help, because what we want to do is keep our patients alive as long as possible. And in patients who have brigatinib and alectinib, we can still potentially give them lorlatinib afterwards, and potentially get their cancer back under control for a short period of time. Do we think about controlling brain disease, which is a major issue with many oncogene-driven cancers, but particularly in ALK, and where these patients are young and it has a major impact on their quality of life? They can't drive. You have to start to use your brain-directed treatments, stereotactic radiotherapy, things like that. And so you get issues like this, where you can see, well, we know lorlatinib is extremely potent in the brain, and if you use it, it's very, very rare for patients to relapse in the brain, particularly if they don't have any brain disease to start with. You control their brain extremely well. So, should we be using this treatment up front? The reason why, even if it comes, it may not have great penetration is, so when you look at osimertinib in the EGFR space, it tends to have a favorable adverse event profile compared to the first and second generation inhibitors, particularly the second generation inhibitors. So it's got less rash, less diarrhea. Lorlatinib, however, it's got a different, again, adverse event profile compared to the previous inhibitors that we use, the alectinib and brigatinib. But some of them are quite challenging and worrisome when we're talking to patients. And particularly because it's so effective in getting into the brain, you start to see adverse events due to this penetration. So that includes things like neuropathy. It also includes things like mood disturbance, hallucinations, and a small number of patients, depression or psychoses. Now, they can all be managed appropriately with dose reductions and stuff like that, how we manage patients, but I think that may lead to lower uptake if this does get approved by NICE, which is not at the moment, but it is now licensed. So the third quick example I'm just going to give you of some of the, that one's gone forward, of the difficulties we have interpreting some of these drugs and how we interpret our clinical practice. And we're going to hear more about this drug later on from Paolo, is selpercatinib, which is a potent RET inhibitor in the small proportion of patients that have a RET fusion. And you get presented this data, and it shows that in the treatment naive, in the phase 1, phase 2, you get response rate of 84%. So that sounds really good. And your response rate in patients in the second line setting, a bigger number, but 61%. So should we be using this? And if we are, should we be using it as a frontline treatment? And but then you look at the progression-free survivals, and in fact, they don't look particularly different. Sorry, for some reason it's doing a lot of skipping at the moment, so my apologies. And then the major thing is, well, these are expensive drugs. So how do you show this is a phase 1, phase 2? It's not randomized. This is a rare population. We've only been testing for it for a couple of years. We don't even know how these patients do normally. We think they may do quite well. They're never smokers. How do you compare to go to NICE and say, well, this is an expensive drug. This is something you should fund because it's going to give me better outcomes for my patients. And so this is a recent paper that was published by Sanjay Popat. And I actually did an open peer review, which is an interesting experience in itself. You put your name out there as part of the paper as a peer reviewer, showing that RET inhibitor patients seem to be better than a synthetic matched population from America. So trying to get it matched to a similar age and demographic, but whether that's good enough for the people who pay the bills is difficult to know. So that's 3 examples. I'm just going to touch on a couple of other issues very quickly about the sort of personalized medicine and how we manage these patients. I'm not going to talk about Sotatercept because of time. I gave a talk at ACP Trainees Weekend about side effects. It is important to think about side effects. You know, I don't have time to talk about it, but you know, each of these has their side effects, and that's the sort of my approach to how you manage these, and that will be in the slide deck that's available to people to go back and look at. But prevention is better than cure in terms of side effects from these drugs, and you need to adjust doses appropriately. So that's all I'm going to say about side effects. Adam touched on testing. You know, the testing environment is changing. I'm heavily involved in this. So how good are we at testing? Well, there was an audit a couple of years ago when we were just doing PCR based, and at that time, most patients were getting EGFR testing, 83% of patients. But even at that time, you know, only where we were just sort of doing EGFR, only 3/4 of patients were actually getting a tablet if they had the mutation. That's very disappointing to me. And this was at a time we were doing simple PCR, which, as Adam said, can be done very quickly. And the median turnaround for results when you're just looking for one gene was 18 days, which again is not great. And we're now trying to do more complicated panel testing. We're trying to get more results back. But what is important is that we do not let those turnaround times drift. And so one of the things that I'm very interested in is, you know, the use of circulating tumor DNA. I'm leading a pilot project in NHS England, some of you may be involved with, where we're looking at trying to do upfront circulating tumor DNA when the patient first sees a chest doctor, and seeing if we can get the results back quickly and get the patient on treatment. And this is the experience of the Marsden, where they showed that at the time that patients came to the Marsden, you could get your medical results back in 1/3 of the time by doing the blood, and you got patients on treatment in half the time. So I think this is definitely going to be part of our practice. I'm not going to talk on that again for purposes of time. Yeah, I know. I think this is important. So immunotherapies with oncogene-driven cancers. So again, what I would say is there's no generic answer to this. There are, if you look on the right, you can see this graph of sort of progression-free survival and tumor mutational burden for some of the classic oncogenes. So the EGFRs, the ALKs, the RETs, the ROS1s, they have very low tumor mutational burdens, and they tend to do very poorly with single-agent immunotherapy. Equally, there's the KRAS mutations, you know, often associated with smoker, have high tumor mutational burden and do very well. And there's some we're not quite sure, for example, the BRAFs, and there's different data out there. Some people say they do well with immunotherapy, some say they don't. But you can't use a generic rule, apart from, I would say, the EGFRs, ALKs, RET, ROS1s, the classic never smokers oncogenes. I would not use single agent immunotherapy for them. And I promised you a cheats guide. So this is my cheats guide, which I share with my MDT. And again, this will be in the thing, but just to show you, you know, the rough proportions of the patients I see in the Northeast, what my preferred treatment is at the present time, key side effects, whether it makes an impact on things like prognosis. So you can see, you know, the ALK patients now are doing extremely well, median survival 3 to 5 years compared to about an average in the UK. Some of these are definitely associated with high rates of CNS disease, for example, the ALKs. ROS1s are probably the RETs. And also whether we need the results prior to starting first-line treatment in the NHS. And for most of them, we only need the EGFR and the ALK result to fill in our blue tick forms. Now, whether that's the right thing or not, whether we should be giving a high ROS1 with a high PD-L1 single agent immunotherapy, well, we shouldn't, in my view. You're allowed to in NHS care, but you have to think about what's the right thing for the patient. So that's a real whistle-stop tour. So do I think the EGFR paradigm is still true? So basically, certainly not true that these patients are rare. These are now becoming a big proportion of my practice. A lot of these now, I'm seeing treatable abnormalities, not in never smokers, the KRAS, the METs, the BRAFs. In general, I think with these targeted therapies, if they're going to work, even the ones that have a lower response rates, they do tend to work very quickly. You will see patients feeling better, often see changes in scans very quickly. But some of them, you don't see responses in all patients. So, you cannot guarantee that giving a patient sotatercept that you're going to see responses in the majority of patients. It's probably just under half. A lot of these therapies are oral. Some of them are not so well tolerated, and some of them have different side effects. And I haven't spent a lot of time on that today because I just don't have time, but you do need to know the side effects. I've talked about the issues about immunotherapy. I think overall we are improving prognosis for these patients. But, I think the number one message is, and I would say this, but that's my job, is that we need to test these patients. But if we get a test, we need to treat the patient. There's no point knowing they have an EGFR mutation or a RET mutation, or particularly these ones which we can only treat in the second line setting and not treating them appropriately. And with that, thank you, and I'm happy to take questions.
Fantastic. Thank you very much for that whistle-stop tour. And yes, it was complementary to your talk at the ACP weekend. That was brilliant on side effects. We do have a question that's just come through the Q&A. So while I read that out, if anyone else could type questions using the chat function. Somebody's asked what you state on the blue tech forms for PS. Presumably that's for osimertinib and getting around the PS 0 to 1.
Yeah. I think this is challenging. So most of them now say performance status 0 to 2. Osimertinib doesn't say 0 to 1. There is no data out there to show that it is not effective in patients of PS2. I think when you're getting to patients with PS3 and patients with PS4, that is different. These are patients who are often very sick, and you have, with all, I have treated patients with PS3, patients with PS4, patients on ventilators and things like that. And it's very tempting to do that with young patients, and particularly the ALKs where they're unwell. I would say that performance status is partly in the eye of the beholder. It is difficult to judge, and not all performance statuses are the same thing. Now, I could hold my hand up and say that I've treated patients with performance status 2 with osimertinib, but I would be potentially outperformed the GMC. But I suspect that there are a number of oncologists, which would probably include myself, who have done that. So I don't know. That's a diplomatic, but it's very difficult to ask somebody so that is a legal form, and if you can be up before the GMC before not filling it in appropriately. But equally, we want to treat our patients appropriately. I would prefer to be working within the auspices of NHS England and trying to change things. So for example, one thing that has just hopefully changed in the last week is that all the forms before said you had to have a histological diagnosis, and I've gone back to NHS England and said, well, look, circulating tumor DNAs and all the guidelines now, a lot of the studies allowed it. This is madness. Everyone thinks it's equivalent, and so they are now changing all the forms to allow for lung cancer to allow circulating tumor DNA pickup. So you can have these conversations, but it's easier if you have data to back it up.
Great, thank you. We've had a few come through the chat. So question here about re-immunotherapy not being well tolerated in EGFR mutant disease. Yeah. Would you give first-line carbo-pem or carbo-pem and pembrolizumab? And what about durvalumab in stage 3 disease? So the example that was given was an EGFR exon 20 mutation. So that's from Paolo.
So I made that example because you don't have anything in first line.
Yeah. So I think EGFR exon 20 disease is different from EGFR sensitizing mutation disease. So is this about EGFR exon 20? Sorry, Paolo, just to be very clear. So I think there we don't know. Again, we're looking at real world data that suggests that they may not do as well with the addition of immunotherapy and may not do as well with single agent immunotherapy. So I do tend to treat these patients with chemo IO, but I'm not sure that the data really supports that. A lot of the issues, and you know, I talked about giving ABCP for the EGFR mutants. Again, I'm not entirely convinced by the data, but I'm not going to give these patients single agent immunotherapy. And then you've got the question, well, you've got a 55-year-old, you know, man with, you know, 2 young kids who's on your watch, you've treated him with osimertinib. Are you going to let him die without giving him some immunotherapy? And I'm not going to give him single agent, so I'm going to give him chemo IO in combination, and I hope he's one of those ones that does well. So that's why I'm saying, you know, it's all very well looking at the clinical data, but, you know, as we become consultants, we have to manage these patients long term. And that's actually the real step up from becoming a registrar to becoming a consultant. Actually, is trying to, you know, and I hope it's not always easy when you only do 4 months or 6 months attachments. It's seen as chronicity, and you may only see the patients at the start or the end of the journey. And being with them on that whole journey, and sometimes you may look at your consultant saying, why are you making that decision? You know, it's not supported by the evidence, but that's because I'm trying to look after this patient for 4 or 5 years. And yeah, the decision I'm making today may not be the best decision based on the evidence, may not even be the best decision, quite frankly, but I'm doing the best to look after the patient.
Great, thank you. We've got 3 more questions, 2 on the chat and 1 in the Q&A. So really interesting question here about using osimertinib in the adjuvant setting. Would it cause issues with it being used in the future metastatic setting because of potential resistance mechanisms developing?
Yeah, and I guess we really don't know that. There'll be emerging data, so the is this question about funding. You know, are you able to do it? And my understanding is that if they relapse after stopping osimertinib, you will be able to treat them in the metastatic setting. But yeah, I guess we really don't know that, and I guess that's one of the concerns of people giving adjuvant osimertinib, is if they are going to relapse at the 3-year mark, you know, what do you do with these patients then?
I know that's something that patients that I have started on adjuvant Aussie, that I've communicated that uncertainty to, about whether or not they'll be eligible or if it will work. Yeah. A question here about sequencing of treatments. Have there been any studies in using EGFR inhibitors in terms of sequencing first generation TKI followed by osimertinib?
Yeah, so you know, that's pretty much what they did in Flora, and you saw that sort of suggestion. It wasn't quite what we would normally do, in that, you know, you have to have the central confirmation and stuff, and I didn't really get time to do it. Yeah, it may very well be effective for some patients. I think in general, because of the toxicity profile, and actually the fact that osimertinib is also very good at protecting the brain. I talked about this in ALK. It has pretty much taken over our first line practice. You know, trying to demonstrate before, when that patients were becoming T790M resistant, was actually quite challenging. You tried to do it on blood, but often didn't have much tumor DNA, because sometimes they were relapsing on the brain or as low volume, and then trying to rebiopsy and stuff like that. So in terms of the EGFR space, I think we've all gone for the easy life, and that's, you know, giving osimertinib up front rather than sequencing.
We've had a couple of questions come through about liquid biopsies. So first question is, if the mutation was not detected on a liquid biopsy, would you still proceed to tissue sequencing as standard? And then on the Q&A, someone else asked, what is the concordance between circulating free tumor DNA and histological assessment? Do you always need tissue as well as blood?
Yeah, so this is well established now, and the fact that they're very concordant from a technical point of view. There is biological differences, so sometimes you won't pick stuff up in the blood because the tumor doesn't shed, or because where it is, or low volume disease. Equally, sometimes on a biopsy you might miss something because you know, you biopsy a necrotic area or poor DNA, or you miss something. Okay, so if you do both, you will pick up more patients. Each of them misses some, but the vast majority of cases in the metastatic setting, they are concordant, and there's numerous projects out there to show this.
Great, and then last question, any role of combination therapy with IO and targeted therapies?
So yeah, that's something that looked very attractive about a few years ago. So there was lots of studies trying to give osimertinib and IO, and we had them run up, and they ran into problems with pneumonitis. There does seem to be some problems with overlapping toxicities. So, for example, liver toxicity when people have given sotaterosib and IO. There may be ways around it. It may depend on your targeted therapy and your immunotherapy and whether you give a run-in. So you may have to give a little targeted therapy run-in to get, make sure everything's settled in. It's not as easy as it sounds. It sounds very attractive. And certainly, 5-10 years ago, that was where everyone was going, all the trials were going, and it's proved challenging.
And one more, we'll make this the last question, but it is quite interesting. Someone's asked about EGFR resistance mechanisms, for example, MET amplification and tepotinib being available. What about other resistance mechanisms? And are we testing for these and any other treatment options that are available?
Yeah, so this is where we're in trials. So in terms of MET amplification, there's tepotinib and capmatinib, both of which have some very interesting data in this space. There are trials running, looking at amivantamab that has MET and EGFR activity, and that actually seems to work, across a range of resistance. There's some other interesting antibody drug conjugates also coming through. Nothing in the NHS at the moment, I'm afraid. Lots of stuff going on in trials. It's always worthwhile talking to your trial centre, making sure that you get yourself access, or that your consultant's got access to the ECMC Trials Finder. But also often, this is the thing, listen to your patients. They're often becoming really active on social media, and they'll come to you with a study, and often you'll say to them, actually, no. But sometimes they'll come to you and go, oh, okay. And so, that's appropriate for this patient and maybe appropriate for the next patient as well.
Fantastic. Well, thank you so much. That was excellent. I really enjoyed it. And thanks for giving up your time to talk to us again, Ali. I will now hand over to Paolo. So Dr. Paolo D'Arienzo is a trainee at the Royal Marsden. He's an ST4 in medical oncology, and he's clearly having a very interesting time at the lung unit there because he's submitted a range of really interesting cases, but is going to be talking to us about RET-rearranged non-small cell lung cancer. So I'll let you share your screen, Paolo.
Nice to meet everybody. So this is a case that we treated about a year ago now. So we said he had RET-rearranged non-small cell lung cancer, and he was unlucky enough to develop recurring episodes of drug-induced pneumonitis, and he also had leptomeningeal disease later on in his disease course. So in terms of demographics and medical background, he was 64 and he was originally from the Middle East. He had a very low smoking exposure with just 5-pack years in terms of smoking history. And also in terms of general medical history, he had only had a TIA a few years ago and not much else. So his oncologic history started in July 2020 when he had severe back pain, had an MRI spine, and that showed bony metastatic deposits, which then triggered a full workup, which did show stage 4 lung adenocarcinoma arising from the right lung with metastasis to brain, bone, lung, liver, and liver metastasis. He commenced carboplatin, pemetrexed, pembrolizumab in the Middle East. He received 3 cycles and had partial response to it. And his original tissue biopsy went through an NGS panel called Oncomine, and that detected RET fusion. The RET fusion partner was KIF5B. And in terms of other oncogenes, there were no co-mutations. And in terms of the PD-L1 score, that was 35%. So he moved to London in September 2020, and we're going to have a poll about what you would do at this point. So would you have continued with carboplatin-pembro until progression because he was responding to it? Would you have stopped the pembrolizumab in view of the fact that we said some of these oncogene-addicted tumors may not benefit from it very much and just continue the chemotherapy part of his treatment? Would you have knocked on the door of the trial unit and trying to get him into a phase 3 trial? That's pralsetinib phase 3. Or would you have applied for compassionate access for RET targeting TKI? We can go, I think.
Yep, so the poll's live. We've had 21 people respond so far. 73% have said continue carbo-PEM, PEM until PD. Nobody's yet said stop Pembro. 13% have said enroll in RET clinical trial, and 17% have said apply for compassionate access to a RET targeting TKI.
Okay, so I'll tell you what. Sorry, how many said apply for compassionate access?
16%, 4 people.
Okay, so I'll tell you what we did. So of course, getting somebody into clinical trial whenever possible is always our preference, but unfortunately, Accelerate doesn't allow patients who are not treatment naive. So that was not an option. And we instead were successful in an application for compassionate access to prasetinib. So that's a RET-specific TKI, and he started it in October. And around about that time, he also had a liquid biopsy with Guardant 360, and the RET fusion wasn't picked up, which is not entirely surprising because that's a ctDNA test rather than an RNA-based test, and no mutations in other oncogenes were detected. He didn't tolerate prasetinib terribly well. Over the course of the next 6 months, he had 3 episodes of pneumonitis, and that's a CT scan showing the bilateral infiltrates that he was developing. And I think we got another poll now. So what would you do? He comes in with that CT scan. We think it's pneumonitis. Would you? So I suppose everybody would give him some steroids, and if he's hypoxic, give him some oxygen. But would you suspend the prasetinib and give him time to recover, and then restart at the same dose? Do the same thing, but suspend and restart at a lower dose. Or would you discontinue the prasetinib altogether? And option C is watch and wait. Option D is switch to cytotoxic chemotherapy. Option E is discontinue the prasetinib altogether and try to get onto selpercatinib instead.
Okay, so we've got some responses coming through. About 50% are saying suspend the prasetinib and restart at a lower dose. 25% suggesting a watch and wait approach, 10% saying switch back to chemotherapy, and 19% saying compassionate access selpercatinib. There's nobody at the moment that wants to restart at the same dose.
Okay. Well, I guess we are full of safe colleagues who don't want to be causing too much toxicity to patients. So I'll tell you what we actually did, which is option 2. So he was treated with steroids, treatment suspension, and dose reductions. So a couple of slides on the drug development pipeline for RET TKIs. So the first papers talking about RET were about 10 years ago now. And then trials were set up for TKIs with relatively broad cover, and they were not selective for RET. So cabozantinib and vandetanib, for example, were used, and phase 2 trial results did include PFS shorter than 6 months and significant rate of toxicities. Lenvatinib was also used. And then prasetinib and selpercatinib came along, and these are highly selective agents instead. And the phase 1 to 2 trials are ARROW and Libretto 001, and they read out in 2020 and 2021. And phase 3 trials in the first line setting are ongoing for both agents. So in terms of the evidence that we have, and this is partly taken from the oncogene addicted NSCLC guidelines, which came out this morning. So prasetinib was evaluated in ARROW. Response rate was 60% in pretreated patients and 72% in treatment-naive patients, and durational response not reached for treatment-naive patients, and almost 2 years for pretreated patients. Selpercatinib, different trial, Liberto 001, overall response rate 64% in the pretreated population, or 85% in the treatment-naive patients, and about 1.5 years duration of response for pretreated patients and not reached for the treatment-naive cohort. Good high intracranial response rates for both of them, possibly slightly higher for selpercatinib, but as you see, we are talking about very small numbers of patients with actually measurable intracranial disease. And ESMO recommendations say that it's important to test for RET rearrangements. NGS is preferred, and an RNA test is required given that it's a fusion. And they recommend both selpercatinib or pralsetinib in patients with RET fusion, depending on what is available locally. Is exactly the same figure that Professor Greystoke has used. So just this is, well, what we're talking about. And then we move on to what happened to him later. So this is something a bit unrelated, but he also made his way into his local district general with a fever and a headache, and he turned out to have Listeria bacteremia and meningitis, which he recovered from. That takes us to autumn 2021, when he was taking half the original dose of pralsetinib after having had those episodes of recurrent pneumonitis. And then in mid-October, he was admitted to a hospital with dyspnea and hypoxia. CTPA was performed on admission, showing no PE, but showing extensive ground glass changes bilaterally in keeping with drug-induced pneumonitis. Pralsetinib was suspended at that point, and he was started on prednisolone 1 mg per kilo. He was rehabbing on the ward, but 2 weeks later, at the weekend, as it always happens, he had a fall. He was found to be acutely confused. The GCS had gone down from normal to 13, and his general fitness had deteriorated significantly. I would say he was an ECOG PS4. MRI head the day after showed progression of parenchymal brain metastasis and widespread leptomeningeal disease. The day after, we did an LP, and the cytology on the LP showed carcinoma. So I think we've got another poll coming up. So what would you have done for him at that point? And assume that you can get access to all the drugs you want. Would you have ring his family and say, there is nothing else we can do, it's time to switch to best supportive care? Would you have considered intrathecal chemotherapy with pemetrexed? Would you have said it's time to restart the pralsetinib that was controlling your disease so well? Would you have taken another ctDNA test to see exactly what resistant mechanisms were detectable? Or would you have switched to selpercatinib at this point?
Okay, so we've got almost half of people responded. 50% so far have opted for best supportive care and calling in his family. Nobody wants to give him intrathecal chemo. One person would like to restart pralsetinib. 5 people, so about 25%, would like to do ctDNA, and another 5 people, so again about 25%, would like to switch to selpercatinib. So quite a range of responses there.
Okay, so I'll tell you what we did. So, we did call in his family and say that the situation was looking pretty grim, but we also got selpercatinib. So he started selpercatinib a couple of days later, and we didn't feel that restarting pralsetinib was appropriate because that had induced so much, grade 3 toxicity, pneumonitis requiring hospitalization. The next poll is about whether you feel that this progression represented tumor flare because he had stopped RET targeting therapy a couple of weeks before, or whether this was acquired resistance.
Okay, so we've had half people respond, and we are split 50-50 exactly.
Oh, wow. Okay. So we had a good chat about this, and we were like, okay, if he had developed new progressing brain metastasis and leptomeningeal disease while he was taking the pralsetinib, then of course it would be acquired resistance. But given that he had 2.5 weeks off between stopping the pralsetinib because of the pneumonitis and developing CNS progression symptoms, then we are probably thinking it was just a tumor flare. And if we had given him pralsetinib, probably it would have worked again, but it was impossible due to the pneumonitis. So what actually happened, he started selpercatinib 2 days later and had rapid neurological improvement, with the confusion having completely resolved and him being able to walk again within 72 hours. 2 weeks after, he went home on his own feet. And in terms of neurological sequelae, he did have a staccato speech, and he did have 4 out of 5 weakness to the left forearm and hand. Fast forward 3 months, time for response evaluation scans. So if you look at the MRIs, I'm afraid they're a bit small and they're not great images, but I can tell you that the radiologist was happy that the intraparenchymal brain metastasis and the leptomeningeal disease, which was present in November, was just no longer there. So it was a complete intracranial response. And we were hoping that the CT would show a response in visceral disease, but unfortunately we had bad news there because there was disease progression in lungs and liver. However, the pneumonitis had completely resolved. So at that point, he was started on carbopem and continued the selpercatinib, with the rationale being that carbopem should control the extracranial disease, and the selpercatinib should control the intracranial disease. Unfortunately, that didn't work, and he had further extracranial progression a couple of months after. At that point, we switched to better supportive care, and he was repatriated to the Middle East, and he passed away in June 2022. So in terms of discussion points, and of course, I'm very happily take any questions. We were very happy we had a Lazarus response to selpercatinib, despite how symptomatic he was from intracranial progression and from leptomeningeal disease. I think he would have died within the next 2 or 3 days if he hadn't responded so well to selpercatinib. Selpercatinib is safe to give in patients who cannot tolerate pralsetinib due to pneumonitis. In Libretto 001, there were no cases of pneumonitis recorded. Instead, there were a few patients in Arrow which did have pneumonitis. I think it was worth it. So, he didn't have an overall response to selpercatinib, but he lived at least 6 more months with good quality of life, and otherwise he would have definitely died within the same admission. We think that probably it was tumor flare as opposed to acquired resistance, but of course we don't have any actual data in terms of liquid biopsy or other tests to prove it. But we think pralsetinib would have probably been effective in treating this episode of intracranial disease progression, but switching to selpercatinib was a great idea for 2 reasons: that allowed to restart targeted therapy to urgently manage cancer-related complications, but also to stay well clear of treatment-related adverse events. When I did that LP, I now look back and I think we should have probably seen whether there was any way of using it for ctDNA analysis. But if indeed he was just having a tumor flare, the only thing to pick up would have probably been the RET fusion, which we would have picked up on ctDNA. But maybe he was truly having acquired resistance, and we would have been able to pick up something else. And the last thing is that this patient was treated in the private sector, and NICE has approved selpercatinib just a couple of months after the events. But I gone through the BlueTech form, and actually the BlueTech form for selpercatinib in pre-treated RET-rearranged NSCLC says that patients need to have good PS, asymptomatic intracranial disease, if anything, and no previous RET targeting TKI. And for these reasons, he would have been excluded from it. And I think actually, given how well he responded to it, I think probably, I think this is a population with a high unmet need that might benefit from this drug. And that's the end of my presentation. Thank you very much for your kind attention.
That was great, Paolo. Thank you. I think it followed on really nicely from Ali's point about the drugs not always being well tolerated. There are often some serious side effects, so the pneumonitis in his case. If anyone has any questions for Paolo, if you could just put them in the chat. Someone did put a question in about what performance status he had, and presumably that's about the PS when he started selpercatinib.
A baseline PS1. So, you know, a well person in his mid-60s with minimal comorbidities, but deteriorated to PS4 on that admission.
And was it on his premorbid PS basis that you were able to access selpercatinib?
No, it was because it was private care and therefore there was no blue tech.
There, yeah.
Can I just make a small point about changing TKIs, which people may not be aware of, is that in general, if people can't tolerate a TKI and there's a suitable alternative, you can switch within 3 months. So even though the blue tech says, some of them now say that you can switch in 3 months, but certainly if you speak to NHS England, they'll allow you to change.
So within the first 3 months?
Normally within the first 3 months.
Oh, that's great to hear.
Yeah, it's a useful tip to know because, for example, we had somebody who was allergic to osimertinib, which I've never come across before. So we had to switch them to a different one. The other thing, I'll just, whilst you're waiting, CSF and ctDNA is challenging, partly because the technologies aren't there, but also the volume of CSF you need to take is a bit scary, to be quite frankly. The volume. Yeah.
I mean, we had already taken quite a bit because I wanted the cytology not to be non-diagnostic. So yeah, maybe it would have been too much.
We've got a question about why the chemotherapy was stopped when he had a partial response before moving to the
I think that's a question for the treating consultant, but I think the rationale was he would have probably continued if we hadn't had access to pralsetinib. So if the compassionate access request had been denied. But I guess the idea was that he's going to do better based on the results from ARROW, that including a pre-treated cohort. But if Professor Greystoke has another idea, I'm quite happy to see what he thinks.
Yeah, I think that it's a difficult judgment call because you don't want to miss the window. You don't want to miss the progression. I would have tended to treat him if I knew that access was likely to be in place. But if there was any question about ongoing access, I probably would have just switched him.
And one question's just come through about circulating tumour DNA. Our understanding was that this could be done for EGFR mutations only. I wonder whether Paolo or Ali, you could share your experiences about doing ctDNA for other actionable mutations.
You can pick up all sorts of mutations on ctDNA, but and there are different tests available, but they are not usually. Some of them will be single gene tests. For example, I think there is a COBAS is for EGFR only, and some of them instead can pick up all sorts of things. But as I was saying, fusions will not be easily picked up by ctDNA tests. But I'm sure Professor Greystoke knows way more than I do on the topic.
So in the test directory, the questionnaire is quite right. The only ctDNA test that's in the test directory is EGFR. We are doing an NHS England pilot at the moment, and there's Marsden activity to see if we can get the more broad spectrum added, at least for those treatable oncogenes. So I'm very much hoping we will. There is access through commercial providers, and some patients, even the NHS setting, will choose to do it. And you can normally get an NHS rate and sometimes even compassionate access to testing. And it's well worth talking to your consultant about it because they may not be aware.
Fantastic. Okay, brilliant. Well, thank you to all of our speakers this evening. I've certainly learned a lot, and I've really enjoyed all of the presentations, so we really, really appreciate it. But thank you to everyone for attending, and thanks for your engagement with the chat and with the polls. I think it was a really interactive session, so great, thanks again.